sincere thanks to Dr. Kaushik Sundar and Dr. Gobind Pramanik, my mentors, for providing me this valuable opportunity. So here's a 48-year-old male who was admitted with complaints of right-sided weakness for a duration of 2 hours. The patient presented to us in the emergency department. At admission, the patient had a right dense hemiplegia with a power of 0/5. The patient had a horizontal gaze palsy with a gaze preference to the left. The patient had a global aphasia as well as the NIHSS was more than 20. So we were thinking in terms of a large vessel occlusion. So on retrospectively probing, we came to know that the patient had a chest pain. The patient also had an ST elevation myocardial infarction, which was diagnosed. The patient was suggested to get admitted in a cardiac center. Patient refused admission and was discharged against the medical advice on antiplatelets. So this is the ECG of the patient showing ST elevation in the anterior leads from V3 to V2 to V6. So to summarize the clinical history, here is a patient who has presented to us with a large vessel occlusion in the thrombolytic and mechanical thrombectomy window with ongoing STEMI for a duration of last 2 days. So this is the CT which shows hyperdense MCA sign involving the left M1 territory, and the second CT angiography showing the absence of flow in the M1 segment of the left MCA. So coming to the problem questions, initially at this point we had two thought processes. Whether do we thrombolize the patient or do we intervene? If at all we are going to intervene, whether the brain takes the precedence or the heart takes the precedence. So to come to the first question, do we thrombolize the patient? So initially we preferred not to thrombolize the patient. So I will just pen down our thought process and the corroborative review article so that we can come on board at the end of the session. So we prefer not to thrombolize the patient. There were two implications we thought of. First is considering the cardiac complications that might arise from alteplase, which could include a myocardial rupture, a cardiac tamponade, or an embolization of the left ventricular thrombus. We consider not to thrombolize the patient. The second is, since the patient had a hyperdense MCA, which was suggestive of a red cell clot, as well as an increase in the density, that is increase in the clot burden, we prefer not to thrombolize. Rather than we thought that we would proceed with a mechanical thrombectomy. Number 3, we looked at the literature and we didn't know the dose of the alteplase to be given in the scenario of a cardiocerebral syndrome. So though there have been some case reports and the low-grade evidence from the ACS stating that a dose of 0.9 mg per kg can be given, but still there are studies which refute the same. So considering these implications, and one more implication we thought was, if the patient is supposed to be posted for an angioplasty, then the patient might require additional antithrombotics, which might include heparin or abciximab, eptifibatide, or other antithrombotics, and that might exponentially increase the risk of hemorrhagic transformation in the patient. So considering all these complications, we decided not to thrombolize the patient. And now coming to the second part of the question, is there an interventional procedure which is needed or which organ takes the precedence? So now let me discuss this into two sections. One is from the neurologist's perspective and another from the cardiologist's perspective. So from the neurologist's perspective, obviously we would be preferring to go ahead with mechanical thrombectomy. And the second is, since the presenting symptom of the patient was a neurological symptom, the patient had a progression of the symptoms, the patient's CT was quite okay. So we thought that there is salvageable brain parenchyma that could be revived after doing a mechanical thrombectomy. So we decided to proceed with a mechanical thrombectomy, and we discussed with the cardiologist as well. They told us that for a patient presenting with a STEMI beyond 24 hours, that is for a scheduled PCI, there need to be certain extra criteria that has to be met for coronary reperfusion. Either there should be no thinning of the ventricular walls, or there should be adequate collaterals, and based on the coronary angiogram, we were about to decide that. So initially we thought that we will proceed with a mechanical thrombectomy. In the same sitting, we decided to do a coronary angiogram done, followed by subsequent plan. So this was the DSA image. This was the left CSA shoot which we took, which showed the complete obliteration of the left M1 segment of the MCA. And subsequently, we did a suction thrombectomy, and we attained a TK grade 3 flow in the particular vessel. And I have just shown the arterial, capillary, as well as the venous phases. And in the same sitting, we did a coronary angiogram, which showed complete occlusion of the left anterior descending artery. Simultaneously, we were looking at the collaterals in the coronary angiogram. So we could identify the collaterals from the right coronary artery as well as from the diagonal branch. I'm sorry, the collaterals were not grossly visible in the image. And then we did a balloon angioplasty and adequately reperfused the vessel. So now the next question, the next challenge we faced was, do we stent the patient? Once again, if we had stented the patient, then the patient might require a dual antiplatelet to prevent a stent thrombosis. But we had opened up we had did a mechanical thrombectomy, we had opened the cerebral vessel as well. So considering the risks of hemorrhagic transformation, we decided not to put the patient on dual antiplatelet. So isolated balloon angioplasty was done without stenting in our patient. So this was the end outcome on day 1. So adequately we have achieved a grade 3 recanalization as well as STEMI grade 3 recanalization. So we were happy with the recanalization. We weaned off the patient from the ventilator. Patient had a significant improvement in the sensorium. He had a motor aphasia. However, he continued to have a motor aphasia he was following gestural commands. He was able to move the right-sided limbs against gravity and against mild resistance. So on the next day, we did an echo which showed an LV thrombus. So the left ventricular thrombus is visualized in the image. Moreover, the patient had an ejection fraction of 37%. So at this point, the next question we faced was, do we put the patient the post-procedural management with antithrombotics? So the coronary artery disease requires a dual antiplatelet. The left ventricular clot requires an anticoagulant, but post-MT, it's not been even 24 hours. So we preferred not like addition of any antithrombotic might increase the risk of hemorrhagic transformation. Now, what would be the further line of management? So this was the next challenge we faced. So at this point, we decided to do a CT. We wanted to rule out a hemorrhagic transformation. Then we decided to rule out edema and other complications of the mechanical thrombectomy, and we decided to proceed from there. And we got a CT done, and we found that the patient had a hyperdensity in the left capsuloganglionic region. We calculated the Hounsfield unit. It was closer to 69. Initially, we thought that it was a hemorrhagic transformation. But since we were planning to put the patient on a single antiplatelet and therapeutic anticoagulation for the left ventricular thrombus, we decided to reconfirm it. So, is this a hemorrhagic transformation or is this a contrast stasis? That was the next challenge we faced. So, we proceeded with a dual energy CT. We set the parameters at 80 kilovolts and 150. We did an iodine subtraction as well as an iodine overlay. So, in the second image where we have depicted, it is an iodine subtraction images. So, since the hyperdensity got subtracted, it was more likely to be a contrast extravasation rather than a parenchymal hemorrhage or a hemorrhagic transformation. So, we just did an iodine overlay as well as we subtracted the iodine. We found that it is just a contrast extravasation. And at this point, yes, we continued with the patient on a single antiplatelet. We decided to anticoagulate with the therapeutic doses of heparin. We discussed with the cardiologist, and therapeutic doses of heparin were continued for STEMI as well as a left ventricular thrombus. And serial monitoring of the brain was done with the imaging, and there was no further hemorrhagic transformation. So now we wanted to reassess both the heart and brain, and it was on day 5. We repeated a CT. There was a hypodensity in the MCA territory that explained the patient's aphasic component. Now we were quite happy that there was no amount of hyperdensity. Now we are quite sure that it is contrast extravasation rather than a hemorrhagic transformation. So evaluating from the cardiac perspective, the EF was still on the lower end. It was 37%, and the patient continued to have the left ventricular clot. So the next question, is there a viable myocardium that can be salvaged with the stage procedure? So this was the next challenge we faced, since the patient's ejection fraction did not improve even after the coronary reperfusion. So we decided to proceed with a myocardial perfusion scan. We did a myocardial perfusion scan, and we noted a significant amount of the viable myocardium in the septal, anterior and anterolateral segments of the myocardial segments, which were in the left anterior descending diagonal territories. So this is the image of the myocardial perfusion scan. So whatever we look in the purple color is the hypoperfused or the viable myocardium, and whatever we look in the golden or the yellow color is the myocardium with the adequate supply. So the apex and the interseptal region were showing a significant amount of the viable myocardium in the perfusion scan. So we decided to reperfuse the patient once again. So we took the patient for cath lab. This time when the angiogram was done, there was almost re-occlusion of the same vessel. The vessel which was previously opened up with balloon angioplasty, we identified that it got re-occluded. So it was opened up with the balloon angioplasty and the stenting was done. So the third image, we could visualize the faint stent which was placed in the left anterior descending artery. And once again, TIMI grade 3, the entire artery was reperfused. So now the next problem question was, after the viable myocardium has been reperfused with stenting, could we continue the patient on dual antiplatelets and heparin? Now, since the last CT did not show any hemorrhagic transformation, we started the patient on dual antiplatelets and we continued the patient on heparin as well. And the last problem we faced was, now things were going on in a fine direction. And are we discharging the patient on dual antiplatelets or anticoagulant in view of coronary artery disease and a left ventricular clot? Now we repeated an echo. This time we were lucky enough that the left ventricular thrombus disappeared and the patient's regional wall motion abnormalities started settling down and the ejection fraction started improving. So we stopped the anticoagulant and continued the patient only on dual antiplatelets after a joint decision with the cardiologist, as the patient had a coronary stent in situ. This is quite a controversial region, and there are certain studies which say that it has to be continued for 3 months. Anticoagulation has to be continued for 3 months. But the exception to that scenario is a stunned myocardium, where we do discontinue the antiplatelets, and I have projected it in my subsequent slides. So the patient was transferred to the ward next day. Patient was discharged in a hemodynamically and a neurologically stable condition after a week's time. At discharge, patient had recovering transcortical motor aphasia with the mild right-sided hemiparesis. This is the image of the patient at the time of discharge. So then we got the histopathological reports and it was consistent with an RBC-rich clot. So before reviewing the literature, I would like to highlight few important points with the case scenario. Actually, the patient presented to us with an acute ischemic stroke, a subacute myocardial infarction, and the left ventricular thrombus. So we did a mechanical thrombectomy for the acute ischemic stroke, and then as a staged PCI, we did balloon angioplasty on day 1 and a stenting on day 7. And left ventricular thrombus was treated with heparin. In the intervening period, we had to use the dual energy CT to differentiate CT extravasation, contrast extravasation from hemorrhagic transformation, as well as a myocardial perfusion scan to assess for the viable myocardium. So we wanted to present this case particularly in the forum because this is a case of metachronous cardiocerebral syndrome type 2 with a left ventricular thrombus. Generally, the prognosis tends to be poor in such cases. With a staged reperfusion, with a mechanical thrombectomy, balloon angioplasty, and subsequently with the stenting. It's like a triple reperfusion therapy. So with the triple reperfusion therapy, we were lucky enough or fortunate enough to have our patient in a good condition. Hence, we wanted to put this patient in this forum. However, there were other controversies or the areas where we bypassed the guidelines, which I would present in the subsequent slides. So this is based on the European guidelines. In view of want of time, I'll just rush through the slides. As per the European guidelines and as per the American guidelines, the last statements mentions that the thrombolysis can be done. And as per the cardiac guidelines, thrombolysis is not indicated in this scenario. Based on 2013 ASA guidelines, it is a relative contraindication. And based on 2016 and 18 guidelines, it has been approved. And based on the European guidelines, it is a contraindication. So based on, there has been a controversy regarding thrombolysis in this particular patient. We chose not to thrombolyze. And coming to the peri-procedural management, we just gave the patient heparin 3000 units as a systemic heparinization, and we didn't use any other antiplatelets considering the risk of hemorrhagic transformation. So just I have quoted a study for that, Mr. Clean study, where they don't recommend giving any intravenous aspirin or higher doses of unfractionated heparin. So timing of the antiplatelet initiation, we started the antiplatelets after 24 hours in view of mechanical thrombectomy. However, there have been guidelines which states that the antiplatelets can also be initiated prior to 24 hours. And the target BP we maintained in our patient after reperfusion was 140, which is coherent with the guidelines. And this is the type 2 acute cardiocerebral syndrome, that is a metachronous type, which is because of the left ventricular thrombus. Type 1 is a synchronous type where both occurs together. And type 3 is where the STEMI is within the window and stroke is out of the window. And we proceeded with the dual energy. The specificity of dual energy CT in diagnosing is 93%, whereas for applying CT, it is 57% in differentiating between a contrast extravasation and a bleed. So we have to differentiate between the contrast extravasation and the hemorrhagic transformation. And the timing of initiation of anticoagulation is between 3 to 7 days, and we choose to anticoagulate on day 3. So how long it has to be anticoagulated? Based on the cardiac guidelines, it's for a duration of 3 months, and based on the stroke guidelines, it still applies the same. But this particular statement I wanted to highlight in this forum because the risk of the recurrent LV thrombus is reasonably high in the first 3 months after myocardial infarction. Yearly discontinuation could be falsely reassuring if the patient has a left ventricular function which remains significantly impaired or the initial regional wall motion abnormality persists, then the chance of a thrombus recurring would be high. So our case, the patient had a stunned myocardium, and hence we discontinued antiplatelets, we discontinued anticoagulation at an earlier stage, and we prefer to continue with the dual antiplatelets. Thank you.